Well, it's my pleasure to host Dr. Martin Fraschetti. Today, we met at ICCMO, and we have the same treatment philosophy, and he's a mentor to me. I've learned a lot from him, and I wanted to share with you a little bit about his bio and then pick his brain about why he does what he does. Dr. Fraschetti graduated in 1980 from University of Detroit. And for about 20 years, he practiced general dentistry, and he received his fellowship from International College of Cranial Orthopedics in 2003, and also his mastership from ICCMO in 2014. And he established TMD Head and Neck Pain Center of Michigan and practiced there for almost 15 years. He established Metropolitan Imaging Center and focusing on TMD, orthodontics, sleep dentistry, functional orthodontics, and full mouth reconstruction, as well as the Dental Implant Institute. He's been a speaker to many seminars. Dr. Fraschetti, you need to take over. I can't keep up with your bio. Please tell me about the seminars or the instruction, which seminars you've been involved in as an instructor.
That's kind of a double-edged sword there. You get to add a lot of stuff to your resume, but that means you got a lot of years in the field, right?
Good years, very good quality
36 years.
So, 36 years, yeah.
Yeah, I kind of got in, I always tell my story, I kind of got in through the back door. When I graduated dental school in 1984, I was fortunate enough to get into a practice with a good friend of mine whose father was a dentist.
Oh.
Okay. And he was a big panky guy.
Nice.
Okay, remember that place? There was a group of them in my neighborhood I used to call them the gold doctors. Everything was gold, But the one thing he was very progressive for his time. Mm-hmm. And he was doing functional orthodontics and TMD. He was treating with Gelb appliance, moras, pivot splints. So getting in with him, he taught me some of that stuff and told me and set me up where to go to learn. So there was a guy that taught functional orthodontics. His name was Walt Brem. He was kind of like, I used to call him the godfather of straight wire. But I started taking courses as soon as I graduated. And lo and behold, I was fortunate enough again to have Gary Wolford, who was my teacher in dental school, who taught oral surgery and TMD. And I loved his course. I knew nothing about TMD, but it made sense. This guy made sense. And he opened a practice up a mile down the road from me.
Nice. That was destiny.
So I had no idea what he was doing in his office.
Being a mile away from
he knew I was doing ortho, and he would call me and say, look, I've got these patients and I need you to do this, this, and this. Can you do it for me? Sure, Gary. So he'd send me patients. Then he invites me down to his office and he's got all this stuff. At the time it was neuromuscular. I didn't know that. And he had what was called a K6I. Okay, it's way before the K7. So I'm hearing all these blips and beeps and watching all these things fly around, and it was intriguing. I'm like, what are you doing? He goes, well, he told me what he was doing. And it started to make sense. It started to show me the connection between the bite and the ortho and why he wanted me to do what he wanted to do. So my back door was learning functional ortho. Wow. Then I got into the TMD. He told me where to go for that. I met, the Mike Mazzacos and the Jay Gerbers and I call them first generation neuromuscular, Bob Jansen. We were all part of the North American Neuromuscular Study Club. That's kind of where that was the farm club. For everything you see today, that was the farm club.
The foundation.
That was it. Matter of fact, that's what birthed LVI. So first generation LVI came from our group.
Yes.
Okay.
Yeah.
So that's kind of how I got into it. And then I started teaching, and I ended up teaching TMD and functional orthodontic in Chicago. I did that for about 10 years. And then we had another company we were teaching out in Cleveland. And then I taught at residency program here at the hospital in the pain clinic. And, you know, I did enough of that. And then I said, look, I don't mind lecturing. Just let me be the guest lecturer. You know? So that's kind of where I got to today. And that's how I ended up doing what I'm doing. Strictly TM, at this point, strictly TMJ, sleep appliances, airway development, functional ortho. I do work with an orthodontist too. So one of my dreams was to be able to someday work with an orthodontist who I happen to grow up with.
Yes, that has always been my dream.
And I have one. And he's a great guy. We're friends. He understands what I do. We work together on these cases, K7s. We do it all. It's our own little thing.
Because
so
they can make the magic that we are imagining, you know, they can make that tooth movement and the magic that we have in mind as far as the orthotropics of, you know, the head and neck and craniomandibular alignment. They can make that, you know, but it's the collaboration that needs to happen.
And he understands it. I mean, you know, and he's up front. He says, look, there's a lot of orthodontists that don't buy into expansion and all this stuff. He goes, I do. He goes, I've seen it happen and I do it. Mm-hmm. And, you know, he'll come into my office and he goes with the patient, he goes, I know what you're going to tell me. You know, when I got the key, he goes, I already know what you're going to tell me to do, you know? And I said, well, good, because we got to do it. So I'm fortunate enough to have, you know, Dr. Hardy and at this point in my career. So
what do you mean by functional orthodontics before you met Gary Waldorf? And what do you mean by that now? How's that changed? Or is it the same thing?
The functional?
Yes.
Well, the story goes in functional versus traditional orthodontics. In functional orthodontics, you're developing. In traditional, you're creating a space based on what you have in your dentition. Mm-hmm. Okay. That is more where if you go, I mean, at least over here, if you go back in time and you remember people getting ortho, what's the first thing that used to pop into people's head when they needed braces? Well, you got to have teeth taken out. Mm-hmm. Remember that? I don't know if you, when I was a kid, that's the way it was.
We still see it. Yeah.
That's the way it was. You know, you're going to have your teeth extracted.
Yeah.
Well, I soon found out that the reason that we got into that, it had a lot to do with the war. Mm-hmm. We had an overabundance of stainless steel in this country. So we made wires. Stainless steel wires for ortho. They didn't have that in Europe.
No.
They couldn't function that way, so they had to create another method of orthodontics. Really, functional orthodontics came from across the ocean.
I never knew that. Never heard that story.
The twin block appliance came out of London. Yeah, I mean those appliances really came.
That's probably why people like me, you know, I was here in the late 70s with my parents and the Islamic Revolution happened. We went back for a trip and then we were stuck there for almost 12 more years before we came back. So from first grade to middle school, I was in Iran. So I got, at that time, you know, I had narrowing of my jaw, and I remember third grade, I had my tonsils removed because I had problem breathing. And then they put me in a functional appliance. They actually gave me a palatal expander. My canine came up here, you know, and they put me in palatal expander and corrected it pretty much by like 80%.
Yeah, really.
But I didn't follow up with treatment because then we moved here. And then I had a consultation and I had braces here, and I'll share with you that story. But you're absolutely right. You know, in Iran, you know, even in Middle East, I think they were doing more functional.
And as far as general dentists learning orthodontics, I mean, you couldn't go to ortho school, and they're not going to teach you how to use wires, right?
Yeah.
So we had to take CE courses, and they were teaching functional. I mean, that was open to anybody. So all your courses back in the day, you know, back in the late 80s and 90s, they were all functional there were a bunch of guys teaching functional orthodontics, all kinds of appliances, you know, and realistically, your DNA appliance is based off of a functional Schwartz appliance.
Yes.
That's where it came from.
Yeah.
So, I mean, you know, outside of the wires and the springs and everything he has in there, the acrylic and the way it fits and what it's supposed to do all came from that. That's it. There's only 3 appliances that you think about: AP, transverse, and up and down. Make whatever else you want out of it. What do you want to do with it?
But then,
So,
so when was it that the traditional orthodontics took over? When was it, do you think? Which
you mean traditional took over? Or,
yeah, but you're saying functional kind of like started in Europe and
well,
then
I think it hit.
traditional, you know.
I think it hit here in the 70s.
Okay.
I think it started in the 70s, and along with that came airway. Jim Gary was around back in the 50s.
Yeah.
He was writing articles. We couldn't take an ortho course without having his book.
Yeah.
Okay, airway first.
Mm-hmm.
He was right. Everything revolved around airway. If we couldn't correct, everybody thought functional development number 1. No, airway's number 1.
Mm-hmm.
Once you get airway under control, if you don't have airway under control, nothing's going to work. Doesn't matter what you do.
Nope.
If you can't take care of the airway, nothing's going to work.
Because muscles push and it just collapses.
If you can't, these kids, you look at them, they're mouth breathers, there's allergies. If you can't keep your lips together and your tongue in place, what's going to happen to your arches?
Mm-hmm. Yeah.
Collapse.
Collapse.
That's
narrow,
it.
Narrow.
The tongue and the lips are what form the oral cavity. And if you can't create that seal, you lose.
Mm-hmm.
These muscles will do this. You compress. And there's 80% of your cases. That's why deep bite class 2s are so popular. It's where they came from.
So why is it that when I graduated 1998, I had no myofunctional therapy courses at dental school. I had
None of them do.
nothing about function closing. I had ortho classes, but nothing about mouth closure, nasal breathing. The whole, the foundation of this structure was not taught. So I never screened for airway. I never looked at my patient's mouth posture until I got involved with, neuromuscular, finding the correct position for the mandible. Yes, but the problem's up here.
A lot of it, there isn't a dental school around that. Maybe there's a couple now, but there wasn't a dental school around that taught any of that. And their default was, well, we don't have enough time. Well, you have enough time to introduce it, okay? And if the student graduates and they want to pursue it, at least they know the direction to go in. We never had that. We got lucky. I got lucky. I landed with a guy who was ahead of his time. Yeah. He picked me up and dropped me off at these courses at where to go. You don't know. And then I started putting 2 and 2 together. Yeah, and I'm like, oh my God. And I think we're at the point now, especially in sleep dentistry, it's a medical problem with a dental solution.
Yes.
Correct? I think they realize, I think the pendulum's swinging even a little bit more now, where they're realizing, this is more of a medical dental problem, yes. Not just a medical problem. It is a medical dental problem.
Yes.
Because it is this dental, orthopedics, whatever you want to call it, that is causing your medical problem.
Yes.
Okay, you can put a medical name on it, but let's really figure out where this problem is coming from here. Okay, you go to any physician. They aren't going to recognize a child that has a bruxism problem or a crossbite, they don't recognize that.
No,
we do. If it's a medical problem, then you need to recognize it.
Yes. Yeah.
See what happens when you're old?
There should be more emphasis on airway. Why shouldn't my pediatrician shouldn't look more at the airway? Look at the mouth posture and see if this child isn't breathing through their nose, especially during this pandemic. If these kids are breathing through their mouth, they're inviting all kinds of bacteria and viruses, no matter what size, they're going directly into their lungs with no benefits of nitric oxide.
How many times do you hear stories where these people that are living in the Andes Mountains are 120 years old? Well, why is that? Because the air is so pure and they don't have all this junk and everything develops the way they're supposed to. If you could get people to breathe properly and develop properly, you could probably eliminate at least 50% of the medical problems they have.
I absolutely agree with you. Yes, I know.
Oxygen's important for everything. For everything, you know? And then you go and smoke on top of that.
Let's hold our breath and see how long we'll
Yeah.
survive.
Let's have a few
Then it's
cigarettes.
maximum probably.
Well, anyway, so, you know, yeah, it's huge, man. Diabetes, you know, I mean, even now cancer. So
I saw
that
a
one,
patient last week that it just really broke my heart. He's an 18-year-old lacrosse player. Actually, he's had some practices with my son too, because he's a goalie for his school. Big guy, 6 foot tall. He's been in ortho for about 5 years with his orthodontist. What happened is the mom found me because he has all his teeth, about 20, decayed. So they found me, they like me for cosmetic dentistry. He comes and I cannot not look at his bite. He was only biting on the 4 molars. They were worn down, and he had an open bite from bicuspid to bicuspid. Forward head posture. I put him in front of the posture grid, his cranial sacral malalignment. And then I started asking questions. I said, I suspected sleep apnea. And I said, do you have any symptoms? Are you foggy in the morning? He said, yeah, I was just put on ADD medication at age 18, you know, and there's no attention to the airway, no attention to the airway. It just breaks my heart because he's moving, he's going back to school, he's going to college, and I only have 1 month with this child to to help him. So I sent him to our chiropractor, trying to align his body a little bit. We did a home sleep test, and we're just gonna see what we can do, at least maybe a rescue appliance to put his jaw in the right position.
yeah, see, it's just another case that was missed, overlooked at a young age.
Yes.
And listen to this. This was probably about 20 years ago. I got a call from a child clinical psychologist, the other side of town. And she's pretty popular, Barbara Fisher. She's written a number of books. She goes, hey, I got a question for you. I know you treat kids and functional on it. She goes, I constantly get these kids sent to my office with ADD. Mm-hmm. She goes, I just don't think they can breathe. She called and says, I just don't think they can breathe.
She's seeing
says,
it.
would you come down to my office and look at some of these kids? I said, sure. Everyone, yep. So we actually had a relationship going for a number of years. I would look at her kids and, you know, do what we needed to do. She goes, I just don't think they can breathe.
Yes.
How about that? So
but there's approaches like yours, you know, that for the past 30 years they have been proven that they work. You've helped a lot of people.
Airway is nothing new.
Thousands of patients. Yes.
Yeah, airway's nothing new. We were expanding palates back in the 80s. I mean, rapid palate expanders, removable Schwartz. We were using them all. We were expanding kids. Mm-hmm. We did it. We did adults. When I was doing, you know, when I started neuromuscular, I was expanding adults. Way back then. Way back.
How did the neuromuscular component helped with your orthodontics, with your expansions?
Well, the short version is if you can deprogram and you can relieve, this is key to expansion. If you can deprogram and eliminate that strain, the maxilla will expand. It wants to. It's not fighting anything anymore. Mm-hmm. Okay? And that's what the orthodontist I work with, he understands that. He knows that. It's never fused. It's not fused. It will expand. Okay? So if you can eliminate, and I know there's a lot of nuevo airway groups out there that are using, you know, skeletal screw appliances that are implanted. You know, I've never had to use that. If I can get a neuromuscular balance and position, I can expand that. Matter of fact, I can even forward pull when I got to protract a mandible or maxilla. Mm-hmm. Okay, I've done that. I've sent I had another orthodontist that was in our courses from Case Western, and he had a hard time believing that that was happening. So I used to send him cephs because he taught at Case Western. So I'd send him all my cephs of before and after. I mean, we had one, we did 6 millimeters on an adult.
With face mask or
With a
without?
face mask, face mask.
Yeah.
Yep.
Nice.
Neuromuscular,
Neuromuscular,
orthotics,
mandible, yeah.
face mask,
Face mask.
anchorage, and away we went.
So did you have these patients in a neuromuscular orthotic all day long and then nighttime expanders and face masks?
Yeah, there's a lot of crossover too. I mean, when you're getting into phase 2, you know, you got your position. You want to maintain a treatment position. Doesn't mean it's your final position.
Mm-hmm.
You want to maintain your treatment position, create your develop orthopedically all the deficiencies that you have. Okay. Now, once you have all that stuff out of the way, we had a big articles on this stuff. Me and Mazzacco used to go back and forth with this years ago. Change AP, change vertical.
Mm-hmm.
I say that all the time, and nobody stops me and asks me, what are you talking about? You know, if you change AP, you change vertical.
Yeah.
Okay, so we used to say, if we change AP, if I change torque, I can change vertical. So you've got skeletal, you've got dental. All those factors come into play as your final neuromuscular position is developed. That's why I'm saying when you're doing ortho, you're developing a trajectory, essentially, is what you're doing.
You're developing
a point on a point of trajectory. Yep.
Because the rug underneath is moving. Yeah.
Mm-hmm.
Yeah.
Now you got to watch when you get into restorative, you know, take note of what may be missing orthopedically in the patient that you're treating. You know, if you're going by a neuromuscular bite, you know, you've got to be very careful. This is why I said, and I just posted this yesterday. Ira was he loved it, but this Shimbashi number can be very misleading in the neuromuscular world.
Yes.
Okay, it's very misleading. So when you're doing a restorative case that has orthopedic issues, that factor becomes even more important.
Mm-hmm.
So you have to be very careful with that. Okay. Narrow maxillas cause mandibles to go backwards.
Yes.
So be very careful with that. Even though, you know, in this point in time, when you're looking at your neuromuscular bite on your computer, it says everything's a go.
Yeah.
But it can't see orthopedics.
I just had a case last week referred by one of our orthodontists in town to me, and she is locked, so you can only get like one finger. She's probably 16 to 20 millimeters open, and anterior open bite, locked, double joints. We just took the CT, and they're both displaced posteriorly, yes, and so they're both joints are locked now. We can't even take scans of her. We're going to do digital scans, get our camera to like try to mount her. It's very difficult, as you said, you know, when you have that. But the problem is maxilla. And, you know, I talked to Dr. Tennant, I said, I can decompress her, maybe get her in a myoaligner, but her problem is not, it's just that drop, you know, that pitch yaw roll of the mandible we need to go through. But the main problem is the narrow maxilla that got her in the first place. And, you know, this is the child who has had an ortho. So
how wide can she open?
Less than 20, like this. There's no way we can get any trays in her mouth. So she's coming back. We just did a consult. She's coming back so I can see if I can scan a little bit in there with our, so. I mean, that maxilla, but so the relationship of that maxilla and mandible is very important. And that's why we need to, I emphasize on collaboration, you know, as a neuromuscular dentist, that's why a lot of people don't even go this far into dentistry, because they cannot find a solution that they can collaborate with other ortho specialists. And you can't do everything yourself as a general dentist. You know?
I've watered it down to a few things now. There's no way. I think I did my last full mouth case 6 or 7 years ago.
Yeah,
And,
yeah, it's a lot of work, so
oh, ton of work.
we need more collaboration between different specialties, we can get that mandible in the right place, and as neuromuscular dentists, I mean, I think with a good TENS unit and with a good 40 minutes of TENS, even a general dentist can provide a good phase 1 orthotic. Doesn't have to have a lot of anatomy, but at least just stabilize the mandible. Don't you agree?
Can get them moving in the right direction.
Yes. Yeah.
It's not the end. I mean, you're moving down the line here. You just got to you got to know where you're going. And once you know where you're going, what you do in between is nothing. You're going to get there. We had we were a big thread yesterday with all of us on appliances. I threw out, just to get everybody's feathers ruffled, I threw out a flat plane anterior, well, it was index, anterior bar, a guy had a maxillary asymmetry, vertical was like this, and they're all like, I said, well, what do y'all think of this? Oh my God, that's not neuromuscular, poor guy. I said, let me tell you what. I said, in less than 2 days, this guy's pain was gone. And I mean, everything. But I said, unless you know the patient, and I said, don't look at it as we're going to treat him neuromuscular. I said, you got to look at the patient, see what you need to do. Yeah. I said, this patient could not tolerate anything on his front teeth, period. Yeah. Nothing. He couldn't tolerate it. I had to create something. This is the Myoaligner. I had to create something where he only had posterior contact. That's it. Now, if he's comfortable, and he is, he's your perfect Myoaligner, segmented case, perfect. I don't have to do anything at the front. If I want, I can bond them, right? We can bond those, right? We can do that. So
the reason we didn't have segmented, I know that gill was kind of like segmented, but connected still with a bar, is because we didn't have the technology. We didn't have a way to create good retention on these, and make them anatomical. And it was tough for us too, in the past few years, we've just been really fine-tuning the design and manufacturing and playing with different appliances to be able to get a right fit. But then we see that a lot of value because, as you said, everything is moving. That maxilla, if it's not trapped by a mandible, that maxilla is just going to relax. And same with that mandible, when it's not under so much tension from clenching and from a compromised airway, they're just going to relax, and your whole body is going to unwind. We'll see the effects all the way down to the toe. But as you said, sometimes, the segmented is the key for these patients to unwind.
You got to look at the patient. If you can see it, I was taught, if you can see it, if you can see what you're doing, you'll know what to do.
Exactly.
You can see it, and in your head what the end product is supposed to. I said, you see this. I said, when I see a patient walks in, they're all gnarly, their teeth are all crooked, their jaws are all. I said, in my head, I already know what they need to look like. Okay, I already know it. Now I just got to get there. Okay. I don't run to the computer and start taking a bite and not know the next place I have to go to.
Yeah.
I know where I'm going. Okay. And sometimes, I got to be upfront with patients. Sometimes knowing what you can't do is as important as knowing what you got to do.
Yes.
You can't do everything.
No.
I mean, we can only do so much with what we have, and things are getting better. Okay. But, I know people are opening up bicuspid, everybody's poo-pooing bicuspid extractions. I did too. And then I thought about it and I said, wait a minute. I can't sit here and look at myself and say every 4 extraction is a disaster. They're not.
No.
They're not.
There's
a lot that didn't need to be done.
Yeah.
Okay. So having said that, you can't say, well, we're going to open up your spaces again. That may not solve the problem unless you totally diagnose this and figure out if you got a class 1 skeletal and a mandible and a maxilla in the right position, and you open those spaces up, you just created a bimax protrusion. Mm-hmm. That may not have been what that patient needed. Okay, what they probably needed was distalization of the teeth. Yeah. I said, that was the problem. They just did it the wrong way. So I said, until you know that, don't say anything. You don't know. So, And there you go. That's the functional world. You know, you ask me what's the difference. That's
Yes.
the big difference.
45 minutes later, that's the functional.
That's the big difference, is being able to understand orthopedics and how it plays and the role it plays in what you're doing, and recognizing what is wrong and what needs to be corrected. Orthopedics follows airway.
Yes.
Airway, then orthopedics. And you can mix and match sometimes, but don't lose the primary goal of your treatment at this time.
Yes.
It's just, you know, don't jump to the end. I mean, I'm a broken record. I mean, people, I told them on the forum, I said, you guys are probably tired of listening to me, but I'm always asking about a diagnosis. Never get one. I said, but I'm always asking about it. I said, because if I don't have that, I can't answer. We're just guessing. We're just throwing stuff out there.
Yeah.
Just throwing stuff out. But, you know, it's a forum. What are you going to do? So when I got in with Brem way back in the 80s, he told me, he said, until you have your diagnosis and at that time it was a Ceph and a PAN and models. We didn't have ICATs. But he goes, until you have your records and your tracings, he says, I can't help you. And I know, now I know what he was talking about.
Mm-hmm.
You know, you don't look at models and treat.
No.
You can't do that.
That's attached to, oh yes, many other structures. Yeah, that's so true.